So we're going to start. So it's my pleasure to introduce Dr. Deshayne who's an associate professor in the School of Epidemiology and Public Health at the University of Ottawa. She's also a scientist in the Children's Hospital of Eastern Ontario Research Institute and is an adjunct scientist at ICIS, or I believe they call it ICS now. Dr. Fell is a perinatal researcher who works extensively with the Provincial Birth Registry, which is called Born Ontario, and with health administrative data held at ICIS since 2009. Since the H1N1 influenza pandemic, her primary research focus has been on the infection and immunization during pregnancy, and she has been a member of 2 WHO working groups related to immunization during pregnancy. So we look forward to Dr. Fell's talk, which is also very timely, and so the floor is yours.
Thank you very much, and thanks for the invitation today. Can you hear me okay?
Yes.
Okay, great. Okay. So I'm going to be speaking about vaccination and pregnancy, but specifically trying to focus a little bit on some of the research that's been done in this area using large linked databases, because I know within CNODES, that's essentially what you guys do all the time. And so speak about some of the methodological challenges as well. I don't have any conflicts to declare, but I do have a few disclosures and disclaimers. So I'm going to start just by giving a really quick overview of vaccination in pregnancy, because it may not be known to all of you. Talk a little bit about the recommendations that we currently have, and then I'll move on to talking about some studies that have been done to look at various aspects of immunization in pregnancy related to safety and effectiveness using large linked databases. And then I'll just speak a little bit about some of the challenges and opportunities of this approach with respect to immunization research, and specifically for pregnancy. And then I'll end, of course, by speaking about COVID, because you can't really not talk about it right now with everything that's going on. And this is a particularly busy time for me. So just a little bit of background. I'm sure, as many of you know, we often are concerned about infection in pregnancy, because we know that there are many types of infection that can cause more severe clinical disease in pregnant people than in non-pregnant people of similar age. And you can see a number of infections listed there. So for instance, influenza is an infection we speak about a lot with respect to concern in pregnancy. And while pregnant people are more susceptible to acquiring infection in the first place, if they do become infected with flu, they are at higher risk of more serious complications. And I think we've now landed in a place where we understand this to be similar with respect to SARS-CoV-2 infection or COVID-19 in pregnancy, where pregnant people don't necessarily acquire the infection more readily, but we have recently especially seen more serious disease. And the reason for this increased disease severity is thought to be, at least in part, due to the many physiological, immunological, and physical adaptations during pregnancy that tend to become more pronounced as gestation progresses as well. Of course, when pregnant people get infected, we also worry about the developing fetus. And so maternal infection, just generally speaking, in pregnancy is one risk factor for a number of adverse birth outcomes, so including things like preterm birth or spontaneous abortion. And of course, we know there are particular pathogens that are very catastrophic if pregnant women get infected in pregnancy. So Zika is a good example of that. And then, of course, after the babies are born, we also worry about infection in neonates and in the first months of life. And that's when we tend to see the highest rates of infection-related morbidity and mortality is in that early time period. So this has become a particular focus, I would say, in the area of maternal immunization because of the potential to reduce infection in the neonatal period and early months of life. So the reasons we immunize pregnant women then are, first of all, to directly protect pregnant women themselves who maybe are under-immunized or unimmunized, or perhaps have waning immunity, which is a problem we've been seeing with pertussis, to also reduce transmission to the fetus and newborn, of course. And then this last reason, I think, is really behind the huge momentum in maternal immunization research and implementation over the past decade, really since the H1N1 influenza pandemic. And that's because of all that we've learned over the past 10 to 12 years about transfer of maternal antibodies across the placenta to the fetus, leading to passive immunity to the young infants. So at the moment, on the left-hand side of the slide are vaccines that are already routinely recommended for pregnant people in many countries around the world. So in Canada, we currently recommend influenza and pertussis vaccination in every pregnancy. We don't have really a specific recommendation for tetanus, but that's because we're a highly vaccinated population already for tetanus. But in countries that are still dealing with maternal and neonatal tetanus, so low and middle income countries predominantly, they target pregnant people for 1 to 2 doses during pregnancy to prevent tetanus-related morbidity and mortality. And then on the right-hand side are some new vaccines that are either under development or have recently been developed in the case of SARS-CoV-2 vaccines. But just to say a quick word about respiratory syncytial virus, which is a major cause of lower respiratory tract infection in young children, and particularly in infants, as well as group B streptococcal infection, which is a leading cause of neonatal sepsis and meningitis. Those are 2 vaccines that are under very active research and development right now for potential future use, specifically in pregnant people. So those are undergoing clinical trials right now, phase 2 and phase 3, but I'm not going to speak any more about that today. And just a final word for background to talk about coverage and uptake. You know, despite the fact that we've had these recommendations for routine immunization, for example, for influenza in pregnancy for a very long time, since 2007 as a universal recommendation, and they're covered, it's free of charge for pregnant people, our uptake tends to be quite low. We don't have easy ways of estimating coverage in pregnancy in Canada. So I've put a few different estimates from various provinces in different seasons. But what you can see is we had quite high uptake in Ontario during the H1N1 influenza pandemic. So it's going to be really interesting to see over the next short while what the uptake is for COVID-19 vaccines in Ontario. And we're just starting to look at that now. We recently looked at coverage for seasonal influenza vaccination in Nova Scotia between 2010 and 14. And this is work that was led by Dr. Azar Mirabadi, who's on the call. And this publication is actually in press right now, but we found about 36%, which was higher than I expected, honestly. Whereas in the US, we tend to see, at least in insured populations, we tend to see coverage for flu of 50% or higher typically, and then even higher for Tdap. So I'm not quite sure why it's still fairly low in Canada. There was a recent survey done by the federal government, by FACT, to look at coverage. This was survey-based in a relatively small sample size, and you can see they estimated coverage for flu of 43% and Tdap of 40%, and this is for Ontario, in 2018 and 19. But what we've recently found in looking at our administrative databases is coverage in sort of the similar time period, somewhere between 16 and 27%. So probably the truth lies somewhere in between those 2 estimates. For Tdap vaccination, this is a relatively new recommendation. So it was just recommended by the National Advisory Committee on Immunization in February 2018. So you can see there's been a sharp increase in the proportion of pregnant people who are being immunized with Tdap in pregnancy. But in the lead up to that, and I think basically following from what was happening internationally in the US and the UK, some care providers were already immunizing pregnant people in Ontario with Tdap vaccine, and we've recently done some research on those earlier years, and I'll speak to that briefly in a moment. And final point, that we know that among the barriers that have been consistently identified in research around the world with respect to uptake of vaccination in pregnancy, one of the leading ones, of course, is concern on the part of the pregnant individual or pregnant women about safety, both for themselves, but particularly for the babies. And then among the strongest facilitators are having safety information that's specific to pregnant people, as well as having vaccines recommended by a trusted healthcare provider and provided at the point of care. Okay, so let's look a little bit at a few illustrative studies that have used large linked databases to study safety and effectiveness. There are so many of them that I can't speak about all of them, so I've just chosen a few. And I just wanted to start off by pointing out the study designs that are the observational study designs that are typically used in vaccine evaluation research in general. So for looking at vaccine effectiveness, cohort and case control studies, which of course, as epidemiologists are kind of our bread and butter. And this includes the test negative design, design, which CNODES hosted a very nice lecture on a couple of months ago by Dr. Mike Jackson. So I'll speak a little bit more about this design in a moment. Screening method is another approach I've seen used in pregnancy. I commented here on, noted here whether I've seen these designs applied in pregnancy. Of course, there are also kind of ecologic or quasi-experimental methods that we often use also to look at public health impact or population level impact. I haven't seen that used in pregnancy yet. And then on the safety side of things, again, fairly conventional designs, cohort and case control studies, which we all use, as well as, and I'm sure many of you in your drug safety research also use self-controlled case series studies. Again, I haven't seen that particular design used in vaccine safety research in pregnancy, but loads of particularly cohort studies, as well as some case control. So we'll look at a few of those. I just wanted to point out that we really don't have a lot of data from clinical trials in pregnancy. There are more coming now because it's becoming recognize that you have to include pregnant people in randomized controlled trials, obviously, with new products and new vaccines. But these are the studies the trials that have been done on influenza vaccination in pregnancy. And so these were all from the past 6 to 10 years, I guess. And all of these were performed in South Asia and Africa. And I'll just show you the results on, first of all, efficacy from these trials. This is a recent review that pooled estimates on efficacy against lab-confirmed influenza in infants under 6 months of age, as well as for pregnant women themselves. And so you can see the pooled VE estimate for infants under 6 months was 41%, and vaccine efficacy of about 61% for pregnant women themselves. So if we look at effectiveness studies in pregnancy for influenza specifically, I thought I would highlight the test negative study, again, because you recently had a very nice lecture on this in the CNODES webinar series, but also because there are just so many test negative studies being published right now that I'm sure you're seeing in the literature and in the media. So I thought it would be interesting to show this design again. So essentially the way these studies are performed is that you have subjects who have symptoms of whatever disease it is that you're studying, in this case, influenza-like illness, who seek care and are then tested. And so essentially those who test positive for the pathogen of interest, so in this case influenza, become your cases, and your test negatives are your controls. And then you're looking back to see the proportion of subjects that were vaccinated in each group. And so the vaccine effectiveness estimate is just the ratio of odds of vaccination in your cases relative to the controls, and it's 1 minus the odds ratio is your VE estimate. So I'm just going to use the term VE throughout this presentation. And one of the strengths of this particular approach is that because you're starting with subjects they've all presented because they have some kind of symptoms and then they've been tested, it kind of reduces some of the self-selection bias due to health-seeking behaviors. There are certainly some challenges as well, and Dr. Jackson spoke a lot about those in his lecture a few months ago. But one of the big challenges with using routinely collected data, like the types of data that we probably use to do these sorts of studies, is that the indication for deciding who to test and who not to test isn't standardized, and this in itself can introduce some bias. And I mean, I think COVID is a very different situation than what we usually have with influenza, where I think there really is a lot of selection happening around, and a lot of probably random factors too around who gets tested and who doesn't. So I'll just show you some results from an international test negative study that I was a part of a couple of years ago. This was led by the US Centers for Disease Control, and you can see the study sites there. So there were 4 countries and 7 sites, including 2 in Canada, and so I was part of the Ontario group. And essentially, we weren't, despite the CDC's desire to have record level data from all of the sites, and we really did try, we couldn't overcome the privacy constraints, basically, that to allow us to ship individual record level data to the CDC for analysis. And so we had to use a common data model approach where we harmonized our protocol and had very standardized definitions for all of our variables and inclusion exclusion criteria and how we did the analysis. And then we essentially meta-analyzed the estimates. So this is the study which was published in 2019 in Clinical Infectious Diseases. And I've already told you about the countries, and we basically looked across 6 influenza seasons. So just post H1N1 pandemic up to 2015 and 16. And so each of these sites was able to link at an individual level records from hospitalization, from pregnancy, vaccination records, as well as lab records with PCR test information on influenza testing. So we included all pregnant women 18 to 50 who had a record of live birth or stillbirth, and their pregnancy had to coincide with the influenza season, which is most pregnancies, but not all. And then we used ICD-9 and 10 codes within the hospitalization database to identify hospitalizations with a code for an acute respiratory and febrile illness. And then from those, we subsetted to those that actually had a clinician-ordered RT-PCR test for influenza within 3 days prior to the admission, right up to the discharge date. And so you can see why it was important to include so many study sites and why, we couldn't have just done this study in Ontario, for instance, because the numbers are quite small. So this is a severe outcome. And because of that, they really were not able to look at this type of a serious influenza-related outcome in the clinical trials that I showed you at the beginning. And so this is where, using real-world evidence is really important. And I know I don't have to convince any of you of that. So you can see there were 598 PCR-confirmed influenza-positive pregnant women. So those are our test positives or our cases, and then 432 test negatives or controls. So 13% of the test positive women were vaccinated compared with 22% in the test negative group. And after adjustment for a number of factors, there was an adjusted VE estimate of about 40% against lab confirmed flu hospitalization. So just to move on to safety, there's a lot more research, I think, that's happened on safety over the past decade or so in pregnancy. And I'm just returning to the trials for a moment to show you some of the key pregnancy outcomes. So obviously, when we think of safety of vaccination, there are different types of outcomes that we would be interested in. There's the classic adverse events following immunization, so the things that we would look at in all populations. And then, of course, for pregnancy specifically, we're very interested in outcomes. So things such as fetal death, preterm birth, low birth weight, and small for gestational age, among many others. So these are ones that were studied in the trials. And so you can see the pooled estimates basically didn't find any association between influenza vaccination and pregnancy, and these outcomes. What you can see here is a reduction, a significant reduction actually in the proportion of low birth weight infants born to influenza vaccinated women, and that's largely driven by this trial here, which was conducted in Nepal, and they actually powered their study for 2 primary outcomes, one of which was vaccine efficacy, and then the other which was against confirmed influenza, and then the other which was low birth weight. So those are the trial results. There are far too many observational studies to go into. If you're interested in this topic, you can look at some of the many systematic reviews that have also been performed, including one that I did with Rob Platt, who's on the call, and some others at McGill a number of years ago. But there are also more recent ones that have been published as well, looking at, again, conventional pregnancy outcomes that we would always want to look at in these sorts of studies, like preterm birth, fetal death, congenital malformations, and so on. So I'll just speak for a moment briefly about the Vaccine Safety Data Link that you may have heard of, and I'll just call it the VSD for short. So the VSD is a research organization. Actually, it's a conglomeration of 7 healthcare organizations ultimately in the United States that combine their data, and they've done a lot of really excellent research on vaccine safety in pregnancy. These are 2 of the early studies that they did. So they're about 7 or 8 years old now. And the first study that they did was looking at kind of conventional APHEs or adverse events following immunization. So things like allergic reactions, Guillain-Barré syndrome, and so on within 42 days after receiving the vaccine, but in pregnant people. And they didn't find any indication of adverse events in pregnant people. And then the other study was looking at more kind of obstetric events during the pregnancy. So things like gestational hypertension, gestational diabetes, preeclampsia, and so on. And again, didn't find any indication of increased risk of those outcomes. And they've done many, many other studies since then. If you're interested, you can go to their website and take a look at information on the VSD. They're certainly, I'm sure, doing research right now on COVID as well, but they haven't released any results yet. This is just showing the sites across the US. So this is also CDC led, and they, in this particular collaboration, they're able to use kind of a centralized secure server. So each individual hospital site transfers anonymous record level data into a centralized server where the data are analyzed as record level data, which is obviously nicer to be able to do that relative to the other approach that I showed that we had to use for the other study. Just wanted to talk a little bit as well about some of the very nice research that's been done in Scandinavia and the Scandinavian countries using their excellent statewide or countrywide databases there. So these are a couple of studies that were done shortly after the H1N1 influenza pandemic, both looking at H1N1 vaccination. And vaccination in pregnancy wasn't at all I don't think it was recommended at all, actually, in these countries before the last pandemic, but influenza at least continues to be recommended now. And so you can see, for example, in this study, which was conducted in Norway, they were able to link together multiple databases, including their immunization register, their communicable disease database, as well as a medical birth registry, to look at, in this case, they were looking at fetal death. And what was nice about this study is they were able to look at risk of fetal death both following vaccination as well as following H1N1 infection. And so what they found was no increased risk following vaccination, but they did find an increased risk of stillbirth or fetal death following infection in pregnancy. And they've done a number of other studies actually since then and sort of found similar results. And this is just a similar study that was done, but looking at other outcomes such as major birth defects and preterm birth, but using kind of the similar databases, but in Denmark. And again, they've done some very nice studies out of Denmark as well. So one area that has been identified as a research gap over the past, again, decade or so, I would say, about safety of immunization in pregnancy is looking at longer term studies. And so this is something, longer term safety, sorry. And this is something I've spent a bit of time working on in the past couple of years. So I'll just tell you about a study that we published in August of 2019 in the British Medical Journal. And the lead author on this study was my former student, Laura Walsh. And this was a study we did to look at 5-year health outcomes in the children following receipt of the pandemic H1N1 vaccine in pregnancy. So during the H1N1 influenza pandemic, we collected information in the birth registry in Ontario, which is called Born Ontario, for a 1-year time period on receipt of the pandemic vaccine. And so I've done quite a bit of research using those data. So this was a population-based retrospective cohort study. We had all Ontario women who gave birth. This was just looking at live births, of course, because we were looking at outcomes in the children between November 2009 and October 2010. So we had the birth registry data, which we securely transferred over to ICES and then linked with multiple different health administrative databases that I'm sure you're all very familiar with, as well as some of the clinical registries and ICES derived cohorts, including the cancer registry and asthma data set, and did all of these analyses at ICES. And so this just shows you the structure of the study, where we had, information that we ascertained about the pregnant women themselves at baseline, with exposure information during the pregnancy, and then we had live-born infants who we followed for various health outcomes for a 5-year time period. So the exposure was receipt of the pandemic vaccine. And again, this was a specific database code in the birth registry itself. And then we pre-specified a number of immune-related health outcomes in the children, as well as some non-specific composite outcomes. And I'll show you what those are in a moment in the tables. And then for the analyses, we use propensity score methods to adjust for confounding bias. So we generated propensity scores and then used stabilized inverse probability of treatment weights, or IPTWs, to adjust for confounding. And we had to use a number of different types of regression models depending on the type of outcome that we were looking at. So in terms of our study population, you can see in total, we had 104,249 children who were included in this study, and about 30% of them were born to vaccinated women. And this is just from table 1, really just to point out that although in our unweighted population, we certainly had some differences in distribution of those baseline characteristics between those who were vaccinated and not, as seen by the standardized difference over 0.1. But after applying the weights, you can see fairly uniform distributions, and the standardized differences were all well below 0.1. So this is table 2, are really our main results. It's a bit easier to see in a forest plot, and I apologize I didn't have time to make one, but you can see we looked at asthma, as well as a number of different categories of infectious diseases, including upper and lower respiratory tract infections, gastrointestinal infections, otitis media, and then just this is a composite of all of those actually. And then we looked at pediatric cancer, sensory disorders, and then a couple of non-specific outcomes. So pediatric complex chronic conditions, just overall health services use in emergency departments and hospitalizations. And then we looked at 5-year mortality as well. And so as with most of my studies, most of the results are null. So they're a little bit uninteresting to look at, but they're very reassuring, which is why we do them. But what you can see is we saw a very small but increased risk of statistically significantly increased risk of pediatric asthma, and then a reduced risk in gastrointestinal infections, which was kind of unexpected. And we went through a number of different sensitivity analyses, and I won't dwell too much on these, but we tried to account for maternal propensity to access healthcare services and things like that. And basically, these estimates really just didn't budge at all. Then the other thing I just wanted to point out is we also had a negative control outcome, which I don't think it wasn't in the table on the previous slide, but this was rates of all-cause injuries. And that was also very slightly increased, but statistically significant. So that's an important consideration, of course. So what we basically concluded is that we didn't see any indication of negative health outcomes in children up to 5 years of age, with the exception of this small increase in pediatric asthma, which again, we're not sure what that is. And the reduction in gastrointestinal infections, again, is sort of interesting. We obviously can't rule out residual confounding. I will say that we've done a couple of other studies now looking at these similar outcomes. And we recently, I'll show you the findings in just a moment, looked at Tdap, and we found a similar reduction in GI infections. But another study, the one that Dr. Marabati has just led and is in press, where we didn't see this association. So not quite sure what that means. And I think there'll be other studies, and I know of a few that are ongoing now that are evaluating similar outcomes. So we've been really lucky, I think, in Ontario to be able to kind of make use of this really robust data platform for evaluating vaccination in pregnancy. And I'll just very briefly mention that in the past couple of weeks, we've published 2 studies from some work that we've been doing on pertussis immunization in pregnancy in those early years. I spoke to that at the beginning of the presentation. So this study was led by another student of mine, Romina Fakrai, and this was published in CMAJ Open. And so here she was looking at kind of conventional birth outcomes. So things like, gestational hypertension, preterm birth, stillbirth, as well as a couple of other outcomes, small for gestational age and neonatal morbidity. And again, for the most part, you see null results. We did see reductions in a couple of outcomes, including gestational hypertension, but that's probably some temporal bias there, I would say, and a reduction in NICU admission as well. And then here's where we used a similar approach to what I just described for the pandemic influenza vaccine to look at outcomes in children up to about 5 years of age in Ontario, looking at the same outcomes. And here again, as I just mentioned, we see a small reduction in gastrointestinal infections again, but as well upper respiratory tract infection, which kind of makes some sense, and just overall health services utilization. Here we also included all-cause injuries as a negative control outcome, and here we didn't have any association with that negative control outcome, which is reassuring. There's been a lot of other safety studies that have been done as well on Tdap, and I just don't have enough time to go into all of the literature, but many of these studies that are cited in these systematic reviews also use different approaches with large linked databases in different study populations, mostly in the US and the UK, because they've had those recommendations for quite a long time. Okay, so I just wanted to speak a little bit about some of the challenges and opportunities of using large linked databases for immunization research, and mostly focused on pregnancy, of course. And I don't need to speak to the left-hand side of the slide. I think we all understand the many advantages of RCTs, and if we could do an RCT for maternal immunization all the time, we would, but obviously that's not possible, and we're seeing that play out in real time right now in this pandemic. But there are some limitations with RCTs in terms of pregnancy research for vaccination. So for one thing, they tend not to be large enough to really be able to robustly assess all pregnancy outcomes that we would be interested in. Because of size, but also because they tend to recruit pregnant people around 27 weeks or later, which means that you cannot then evaluate things such as miscarriage or congenital anomalies. Some of the early pregnancy outcomes that are very important, they've already missed the window, the exposure window of relevance for those outcomes. So that's an important limitation. And then obviously the usual limitations around generalizability and as well short follow-up. So looking at longer term health outcomes is often not done in these studies beyond about 6 months or so. So obviously using real world data, as we all know, is a big advantage. So we can look at populations such as pregnant people who are often excluded from trials. We have much more heterogeneity in populations that we can observe with our real world data sources, large sample sizes. We can look for long periods of time to do longer term follow-up. It's in general a lot more efficient and cost effective. And then from a kind of a vaccine public health perspective, it's also really important because we can look at things like vaccine coverage in the population, which is really important, incidence of vaccine preventable diseases, background rates of rare adverse events following immunization. So that's really important right now. And we've seen a lot of publications about that recently. And then, of course, looking at real world vaccine effectiveness and public health impact. And we're seeing lots of papers coming out right now on this topic. There, of course, are a number of biases. These are not unique to doing pregnancy studies or vaccination and pregnancy studies. There are a lot of challenges also with using real-world data around potential sources of bias that can be introduced due to differential healthcare seeking behaviors in certain populations, different clinical spectrum of diseases that you might observe in different databases, things like inconsistent documentation or inconsistent decision-making around testing, and we see this for influenza. I mentioned this earlier. Miscoding obviously is going to then impact what we can measure in our studies, and then other issues such as the fact that we really don't have enough validated algorithms for many of the outcomes that we like to study in using databases, as well as some limitations around the depth of clinical and demographic information that we have in the databases. And again, this is general, not specific to pregnancy. And then just superimpose on top of those challenges the fact that perinatal epidemiology really is difficult. And I'm sure there are quite a few of you on the call who do drug safety evaluation in pregnancy or other types of perinatal epi studies. And they're really quite difficult. There are some biases that are kind of unique to this area and sometimes not all that well known, at least to newcomers, I guess, to this type of research. So in addition to the usual biases, our usual information selection and confounding biases, some of the other unique ones include things like fixed cohort bias, selection of only live births, the fact that we can't observe often pregnancies that end before 20 weeks, time-varying exposure, although that's certainly not unique to pregnancy, but it does cause some big problems in pregnancy, as I'll show you in just a moment, and seasonal variation, and I'm going to speak about that briefly in a moment as well. This is just a quote from the WHO, actually, just kind of stating that observational studies of vaccination and pregnancy are prone to many types of bias, and I won't read through the whole quote. So two that I'm just going to very briefly call out amid that long list that I just showed you are confounding bias and temporal biases, temporal issues. So confounding obviously is always a problem for our observational studies in any population, but what we tend to see in terms of vaccine research, not just in pregnancy, but in general, is that, you know, if you're thinking of something like influenza, let's say, that there's often, you know, selective receipt of vaccine by lower risk people, meaning that those who opt to receive flu vaccine are often kind of generally healthier than those who don't. And so it tends to bias our estimates in the direction of making influenza vaccination look more protective than it is, and often quite a bit more protective than it would logically be, just based on what we know about influenza and how well the vaccines work. And again, Dr. Jackson spoke quite a bit about this in his presentation. And then temporal issues are complicated in these studies, and especially I think for seasonal diseases like influenza and definitely COVID. So we have time-dependent exposures as well as outcomes for pregnancy. And then we've got this kind of background dynamic of what's happening in terms of viral circulation in the community, as well as very seasonal availability of vaccine, at least for influenza. And so these cause quite major issues. And so this is a very nice study that was done through the Vaccine Safety Data Link in the US to kind of demonstrate the impact of some of these issues on our estimates. Because there have been, as I'll show you in a moment, a lot of studies that have found you know, very protective risk reductions in kind of general pregnancy outcomes. So things like preterm birth, for instance, following influenza vaccination, and to an extent that you wouldn't expect based on what we know about influenza and pregnancy and effectiveness of the vaccine. So this is just to show their approach. They started, this is looking at preterm birth. In their first model, this is just a purely naive model, unadjusted for any confounders. And you can see that right away, what you'll always, I think, see is a reduction in preterm birth in vaccinated individuals compared with non-vaccinated in pregnancy because of some of those biases I just spoke about. So then they sequentially went through a series of kind of corrections. So the next correction they made in model 2 was they adjusted for time-dependent vaccine exposure. So meaning, so I think this is their actual exposure variable. So were they correcting for the unvaccinated person time and a vaccinated person time within a given individual? And then in the next model, subsequently adjusted also for temporal access to the vaccine, because for flu, we only vaccinate typically between kind of October and February. So it's only available in those time periods. So they added another correction for that. And what you can just sort of see through these various corrections is that the risk ratio just comes closer and closer to the null value, essentially, and probably to a magnitude that's much more realistic based on what we know about the epidemiology. But there are plenty of systematic reviews out there that you know, just put all of these studies together. And so these are all studies looking at preterm birth, and on the left-hand side of the vertical line is, you know, favoring vaccination in pregnancy. So showing some pretty large risk reductions against preterm birth. As you can see here, an odds ratio or risk ratio of 0.63, for example. So without even seeing that final line, we could have just done this meta-analysis in our head and known that there would be a significant reduction if you pool these studies together. And indeed, that's what they found, and that's what was published. But just because you can combine them doesn't always mean that that's a great idea. So this is just some unpublished data from colleagues who've been working on a systematic review very recently. And what they've done here for seasonal influenza vaccine, and this is preterm birth again, is they've stratified into two groups. So the top group are the studies that used a time-varying exposure approach. And what you can see in these studies is basically no association between influenza vaccination and pregnancy and preterm birth. Whereas in the lower panel, among the studies that didn't account for time-varying or time-dependent exposure, you can see that the pooled estimate here is 0.86. So, and again, most of them are to the left of the null value, and some of them have fairly large reductions estimated in their study. And then similarly for pandemic vaccines as well. So again, the top studies are those that accounted for the time-dependent exposure, and those on the bottom did not, and found a significant reduction. So it's very important, and these do have big impacts. And I think it's, one thing that I've seen, I guess, internationally and in terms of policy, is that this isn't just sort of an academic exercise. It actually makes a big difference, because some funding, investments, and policy decisions are made on the basis of some of these data. And so it's really important that we have good data on risk and benefits, potential benefits as well. Just a final word about vaccination in the first trimester. This is, particularly challenging part of perinatal epidemiology. There are obviously a number of really important outcomes that are relevant to first trimester exposure, but it's also an important risk window potentially even for a later adverse outcome in pregnancy. So it's an important time period. There's a lot that happens, of course, in the first trimester. I've already made this comment that the trials, and including other trials that are ongoing now for RSV vaccines and GBS, they only recruit and vaccinate pregnant people in the late second trimester. The COVID trial that's started now with Pfizer vaccine is the same as well. So these are particularly challenging. There are some very nice studies, including recently, that have looked at congenital anomalies, miscarriage, or other later outcomes. These are all quite recent publications in the past year. And all of these studies have not found any association between first trimester exposure and those outcomes, so which is reassuring, and our evidence on first trimester exposure continues to grow. If you're interested in some of these challenges and reading more about some of these things, you can take a look at these two papers that go through some of these challenges, as well as some of the other ones that we've seen in this literature. Okay, so just to wrap up really quickly, because I'm running short of time, a little bit about safety and effectiveness evaluations that are just beginning on COVID-19 vaccination and pregnancy in Canada. As you know, this has been a rapidly evolving area for research, looking at the impact of COVID itself, COVID infection or SARS-CoV-2 infection in pregnancy. Over a year ago, when the pandemic first started, I think the early case reports that we were seeing initially from China sort of concluded that there wasn't any increased risk in pregnant people compared with non-pregnant populations, but the evidence on that has really shifted over the past year, and particularly quite recently. This is just from a living systematic review that was recently published in the BMJ, just showing pooled results from a number of international studies, basically showing increased risk for ICU admission, ventilation in pregnant people. This is compared with non-pregnant, as well as ECMO. And then if you compare infected and non-infected pregnant individuals, also some increased risk for some adverse perinatal outcomes as well, such as stillbirth and admission to NICU, for example. But more recently, I'm sure you've seen this in the media, but here in Ontario, at least, it was really very prominent in the media, because at one point in late April, I think there was at one point about a quarter of individuals in the ICU in one of the large tertiary hospitals in Toronto were pregnant. So all of a sudden, we've been seeing much higher rates of infection, not just in Ontario, but in other provinces in Canada, and more severe illness than we were seeing in the first and second wave, for sure. So in terms of policy around and recommendations around COVID-19 vaccination and pregnancy, I'm sure you all know that pregnant people were excluded from the trials, and there is a phase 2/3 trial now that's been started with Pfizer that's recruiting about 4,000 healthy pregnant women, again, at sort of mid to later pregnancy, and that's ongoing. But here in Canada, from a national perspective at least, our policy statements from the National Advisory Committee on Immunization have obviously changed over time, initially from a position of not offering COVID-19 vaccine because there were no data, to now quite recently saying that it may be offered to pregnant individuals because we now have some data, which is fantastic. So a lot of national immunization technical advisory groups and obstetrical and gynecological societies have recently come out with statements quite strongly recommending vaccination and pregnancy, and these are just a few of them. This is from the UK, the US, and this is here in Ontario a few weeks ago. So really the best data that we have thus far about safety of COVID vaccination and pregnancy, I'm sure many of you saw this in the media, This is from the US, and it's reporting from the VSafe registry, which is run through the CDC. So this is an active voluntary-based registry, and it's smartphone-based, so it's all participant reported. So they're using this in the general population, but also collecting information on those who self-report as being pregnant, and then recruiting them into a pregnancy-specific kind of sub-study as well, where they collect a lot more specific information about pregnancy outcomes. And so just very briefly, what they found when they compared about 30,000 pregnant people to 1.6 million non-pregnant, just to look at local and systemic reactions, they really didn't see a lot of difference between those who were pregnant, which is shown in dark blue, and non-pregnant in the light blue. So the top panel is Pfizer and the bottom panel is Moderna. And then in terms of pregnancy outcomes, they were limited to about 3,900 who had enrolled in kind of the VSafe pregnancy sub-study, and only 827 at this point had given birth. And when they looked at outcomes such as, for instance, preterm birth, the cumulative incidence was about 9.4% compared with a background expected rate of somewhere between 8 and 15 in the United States. And similar comparisons between other pregnancy outcomes didn't give any indication of concern. And there are other, there's over 100,000 pregnant people in the US actually who've received an mRNA vaccine so far. And it's been very, very widely used in Israel as well. And I think we'll see some research coming out of there quite soon. This is today. This is on the COVID-19 Immunity Task Force webpage as of today. It was just announced that we've received funding here in Ontario through Born Ontario and the Geo Research Institute, which is where I'm based, to do some similar research to what I've been describing, to look at COVID-19 vaccination and pregnancy. So we'll be linking the Ontario Provincial, the COVAX database that we have here that's maintained by the Ministry of Health, with the Born Ontario Birth Registry to study pregnancy outcomes. I don't think I have a lot of time to go into this, so I'm just going to wrap up because I wanted to just mention, actually, I will mention this very quickly to say of the issues that I was discussing earlier with respect to influenza vaccination, in collaboration with some colleagues, including Dr. Platt, who's on this call, we updated that guidance to reflect COVID vaccines, because I think it was a good timing to kind of bring these issues into the forefront again. There are a lot of new people doing vaccine research and vaccine and pregnancy research, and these issues really are complex, and so it's important to discuss them again, I think, and in this context. And I think that, some of the temporal issues in particular may really be accentuated in the context of COVID, and potentially even some of the confounding issues as well. So this was published in March in Vaccines. You can have a look at that if you're interested. And this is just a figure from the paper where we talk about some of the complexities around the time-dependent exposure, which is not quite as simple as it was with influenza, because we've mostly got 2-dose vaccines, and we may even have boosters coming on board. And those are just showing some of the complex temporal dynamics. And again, you can read the paper. And just a final word to say that the work that we're just starting in Ontario through Born Ontario, we're also collaborating with the Canadian Immunization Research Network, Provincial Collaborating Network, or PCN. This is a study that's being led by Jeff Kwong and Shannon McDonald, and there are 5 provinces who are participating in this to look at safety and effectiveness in the overall population, but also, those are just the participating provinces, but also in some target special populations as well, which includes pregnant individuals. So we'll be collaborating closely with the PCN to, we'll be using Born Ontario essentially to do the Ontario piece, and in the other participating provinces, they'll be using the healthcare administrative databases. So that's it. I'd just like to acknowledge a few people who helped me with these slides, or from whom I took information from previous presentations, and I'd be happy to take any questions at this point. Thanks.
Thank you very much. Very clear presentation. We're gonna, I guess we have some time for questions. I guess it was very clear.
Maybe, yeah, maybe it was very clear.
I guess I have one question. So you discussed the temporal issues surrounding vaccination. I was thinking about, are there any spatial issues, geographic location? are some areas more prone to get vaccinated, and can that also be associated with certain outcomes?
Yeah, that's a really good question. And to be honest, I'm not sure. I haven't really looked at it specifically, or at least not for a long time. I think a number of years ago, I was looking at some geographic variability in uptake of the H1N1 vaccination in Ontario, and I was looking by public health unit region. So there's about 37 public health units in the province, and so kind of parsed out the province that way. And there was a fair amount of variation, not quite as much as I'd hoped, because I was actually hoping to use that as sort of an instrumental variable for looking at some outcomes, and it didn't really work out that well because the variability wasn't as high as we expected. But I'm sure that would really depend on context and location. Like I can imagine, there's probably quite a bit of variation across and maybe within some US states, for example, as well. We haven't done a lot of looking at geographic variation in Canada.
Well, thank you. We have a question in the chats. Is the Canadian COVID-19 vaccine registry for pregnant individuals available for residents of other provinces?
That's a really great question. So I was rushing my slides at the end. So in addition to the Ontario study that I spoke about that we're just beginning, also being funded by the COVID-19 Immunity Task Force is, it's called the Covered Registry. So it's basically running out of UBC as part of the Can COVID network, which is a national collaboration of people from every province and territory. We've been working on surveillance of infection and pregnancy, and now we've kind of pivoted to also looking at vaccination. So this will use a really similar approach to the VSafe approach that the CDC is using, such as I showed in that paper a moment ago that was just published in NEJM. So that's it's voluntary and also participant reported outcomes. And yes, individuals from any province can participate in that if they're pregnant or breastfeeding, pregnant and lactating people. And they don't necessarily even have to receive the vaccine because they're also doing some surveys on attitudes toward vaccination and pregnancy and so on. So that is, I'm just trying to think of the website if anyone's interested. I think it's HTTP, the usual, and then covered.med.ubc.ca. is where you can find that information.
Okay, great. We have a question from Dr. Suizo.
Hi, Dr. Suizo.
Hi, thank you very much. This was a wonderful talk, as usual. I have a question on effectiveness of vaccines, so flu or COVID-19. It's more of a general, but I think it does certainly apply to pregnancy as well. But if we're studying effectiveness, you need, for the outcome to occur, you need also the exposure. So you are vaccinated, but then you need to be exposed to actually catch the virus and then to be able to measure effectiveness. And I don't know, there must be some kind of, I don't know the field of vaccines, but it must be a huge challenge to actually evaluate effectiveness in this context where, for example, you can have a complete confounding by indication where the vaccinated people stay home and are never exposed to the flu, for example, and the unvaccinated are outside and they catch the flu. I mean, somehow there must be something beyond immortal time bias and beyond these other biases that you mentioned.
Yeah, I think
illuminate us, please.
Yeah, I think that's a really great point. I haven't really seen that assessed in the context of flu, but I would say for COVID, certainly what we've been trying to do, this is outside of pregnancy, this is as part of the PCN work that Jeff Kwong is leading that I was just speaking about. One of the things that we've been doing in that study is adjusting for occupation, and also the vaccine registry itself has some information on kind of priority grouping, which is probably a bit less important now than it was early, like back in December. So we knew sort of who are the healthcare providers, frontline care providers, front-facing essential workers. So we had that information. And then the other thing that Dr. Kwong did was adjust for the number of tests received before the vaccine was administered, because again, that's kind of an indicator of high risk of exposure. So again, those are likely to have been healthcare workers and other frontline workers. So that's just two examples. And I'm sure there's other ways that you can try and get at that as well. Yeah, well, actually, I have seen one pregnancy study. It was a seroepi study that was done a number of months ago now. And one of the things they did was just kind of adjust in their model for ecologic level, like some sort of a geographic region, the kind of the force of infection, as it were, like the rates of infection in the general population in that region at that time. So that might be one other thing that could be done.
Eventually, maybe in 50 years, we'll be able to merge these data with the usage of online purchasing versus in-store purchasing. So you get an idea of whether the people are outdoors or indoors. And eventually we may be able to get to this a little better. Thank you again, Deshayne. It was wonderful. I'll let others ask questions.
Thank you.
Thank you. Any additional questions? Okay. So I guess we'll just end a little earlier, just by a minute or two. So I'd like to, on behalf of CNODES, I'd like to thank you, Dr. Deshayne, for your beautiful presentation. Actually, we do have, no, that's just clapping. So wasn't that. So thank you so much. And for everyone for attending, we're going to have one more presentation next month, and it's going to be the final of the season. So thanks everyone, and thanks again, Dr. Fell, for your presentation.
Thanks very much for the invitation. It was my pleasure. Take care, everyone.
Thank you. Take care.
Bye-bye.
Bye-bye.